I'm Dave Esposito. I'm a board-certified vascular surgeon. I work here at the Milford Vascular Institute, and the next patient that we're going to talk about today is a 77-year-old female who comes to us with main complaint of pain in her legs. The pain is worse with walking and is relieved with rest. So anytime we hear that complaint in vascular surgery, we think about blockages in the arteries. Blockages in arteries occur from the buildup of plaque. Plaque builds up because of smoking history, hypertension, diabetes, high cholesterol. Those are all risk factors for the buildup of plaque in vessels, what we call peripheral arterial disease, or PAD. If that's the case, there are some things that we can do to try and alleviate those symptoms. Typically, patients who come in will have some routine testing. The easiest thing we can do is we test blood pressures in the arms and the legs, and we compare them. If the pressures in the legs are lower than the pressures in the arms, then we know that there's a blockage somewhere. And then a quick ultrasound, which is safe and easy and painless, can show us where the blockage is. This patient, unfortunately, had complete blockage in both of her legs. So basically, from the groin to the knee, there was no blood flow. All the blood was going through what we call collateral blood vessels, so little small branches that went down and were feeding the whole foot. So you can imagine that that's not very efficient, and it doesn't deliver much blood and oxygen. So anytime the muscles need to work, which when you're walking, there's not enough blood flow there. And so your body senses pain, that's telling your brain to stop walking. So this patient is kind of typical in that, she developed these symptoms and these blockages. Because of all these risk factors and her age, when you're considering how to treat her, obviously you want to try the safest, least invasive things possible to start with. Medications in her did not alleviate her symptoms, and so where we are now today, we're going to bring her to our office-based lab, which is a angiography suite. She'll get some sedation. She'll probably sleep through the whole thing. And we're going to go in through the groin. We'll take some pictures, and then we'll try and fix that complete blockage. The problem with complete blockages are sometimes you just can't get through them, right? These plaque develops over time, and over time it solidifies, it becomes almost like concrete. So it can be very difficult to get a wire across the blockage. And if you can't get a wire across the blockage, you can't fix it. So then the only option would be for a surgeon like myself to do a surgical bypass, which in her case would be exceedingly risky. So hopefully we'll be able to cross that lesion. And if we can cross it, then we can fix it. Typically the way we fix it is using balloons, a procedure called angioplasty, where we blow up a balloon in a blood vessel. Atherectomy, which is where we actually remove plaque using various instruments. And finally, stenting. Stenting is where we place a metal tube, and this is an exact type of stent we will use in an artery. So it's a metal tube that goes inside the artery, pushes the plaque up against the wall, and holds that artery open. So it's basically reinforcing the lining of the artery, so now the blood can flow through the stent and down distally. And that's a more long-term solution a lot of times than just doing balloons or atherectomy alone. Sometimes we combine all three of those procedures. The bottom line is whatever we can do to get this artery open and keep it open so that she can get blood to her foot, relieve her symptoms, and really prevent the progression of disease, which can oftentimes lead to amputation. So that's the case we're going to do now, and we'll see how it goes. Thank you. So we gain access to the artery, in this case the left femoral artery. We're going to be working on her right leg. We always use the opposite leg if we can, so it gives us more room to go up and over. This is the catheter that's going to direct our wire. Come up and down to get to our right leg.
Do a quick look. See what it looks like.
We'll shoot some dye in here. The dye will be black, follow the blood. See the blood flowing. Common iliac artery, external iliac artery going down. So now we're at the groin, so we're going to shoot down here to the leg. Superficial femoral artery should be right here. And what you can see is that it's common femoral artery, profunda femoral artery, but there's nothing here. The superficial femoral artery is supposed to be here, but it's not, so it's occluded. So what we're going to do is we're going to keep looking down the leg and find out where that artery resumes flow in it. You can see here's profunda femoral, there's nothing here, but you can see through all these collaterals, it joins up right here, and that vessel then comes in. So this is the distal part of the superficial femoral artery that's being fed through all these collateral flow, but there's no direct flow into the leg. So you'll see it come around, you're going to see the artery come in here, and now it goes down to the leg. Popliteal artery. Popliteal artery coming down. There should be 3 vessels going down to the foot. Here's anterior tibial, perineal, posterior tibial. So it's actually not bad. It's kind of petering out. So now we know what we got to deal with, but somehow we got to be able to get a wire through the blockage. There, down. In endovascular surgery, everything is about the wire. If you can get a wire across a blockage or a stenosis, you can fix it. If you can't get a wire across, you can't fix it. So in this case, where it's 100% blocked, it's basically like cement. But if we can get a wire somehow to get through the cement or on the side of the cement back into the artery, then we can fix it. And that's going to be the hard part of this case. Now we're going to be putting a sheath in there, and we're giving heparin 5,000 units. Heparin is a blood thinner. We give that so that while the catheter's in, while we're working, the patient doesn't have any clots or thrombosis. So we always use a blood thinner while we're working in the artery. So again, this is where the artery is supposed to be. It's blocked, so we're going to try and work that wire through the blockage down and connect it to the dot below. That's where Dr. Davis works his magic.
We'll see what we can do today.
The artery is kind of like an onion. So if you think about the wall has various layers. So if this is blocked, you get the wire between a layer and go down and then get back into the blood vessel. So you're kind of going around the blockage outside of the blood vessel and then go back into the blood vessel. And that's fine because we're going to be putting it, we can put a stent or something. So we're going this way, but this is probably not in the blood vessel. It's probably on the side of the blood vessel, but that's all right. We're just going to try and get back in on the other side of the blockage. And you can tell because of that loop that it's not inside the blood vessel. It's outside the blood vessel in the layer of the wall, what we call dissection plane. Does it come back? So what we're going to do is we're going to leave that there. Now we're going to take a shot and we're going to see where we need to go to. Okay, so right here. So basically, we got to get the wire down to that level and then pop back into the blood vessel. So now you see the wire going. The question is that in the blood vessel or out of the blood vessel?
The telltale sign is if you have blood come back.
You see the blood coming back. So we'll take a picture and see. So again, what we've done is we've gone out of the artery, down into the artery. So we're basically, and we're in it. We can fix it. So what Dr. Davis is humble. What he just did in 3 minutes, there's not many people in the world who can do what he just did, and he did it in 3 minutes. So it looked easy, but trust me, most people would abandon that case before starting. Now we're going to go ahead. Once you get the wire across, we can fix it. So now comes the easy part, fixing it. So what we're going to do first is, because it's so tight, we're going to put a little balloon in there, blow it up. It gives us just a little space so that all this, our IVUS, all the stuff we're going to do later can get through. Okay. So this is just, we're going to blow up a balloon here. When you blow up a balloon inside a blood vessel, it's called angioplasty. So angioplasty is we're blowing up a balloon, we're fixing the blood vessel. And this is just going to create more space for us to be able to fix this. So here's the end of the balloon. So you're going to see this balloon blow up. So here comes the balloon inflating. It's a 3 millimeter balloon, so it's just creating a 3 millimeter channel through that blockage so that we can get the rest of our stuff through it. Inflating the balloon. So next what we're going to do is we're going to do something that's called intravascular ultrasound, or IVUS. So this catheter here has a little, believe it or not, an ultrasound probe on the end of it. So we all know about ultrasound, you know, when you're pregnant, you ultrasound the baby. Well, this we can ultrasound from inside the blood vessel. So we put this in the blood vessel, and we can take a three-dimensional, 360-degree picture inside the vessel. What this does is it allows us to see the blockage, see where we are, make measurements. Angiogram's limitation is that it's a two-dimensional picture, so you can't get the full measurements and things, but IVUS has really revolutionized how we can take care of patients and you know, pick the appropriate sizes for our intervention. So this next step is going to be what we call intravascular ultrasound. While Dr. Davis is loading that up, I just wanted to show you the balloon. So this is the balloon that's inflated now. So you can see nice long balloon there, and it's filled with water, and so that presses against the wall and it pushes the plaque up against the wall to create a channel through a blood vessel. So this is the intravascular ultrasound. So the black circle in the middle is our probe, and now we're looking from inside the blood vessel out. So this is a 360-degree picture of the blood vessel. So you can see the wall of the blood vessel there.
You ready to record? No, recording. Here we go.
Okay, so we're in the popliteal artery, so it's open and flowing. We can see it. See that the vessel is shrinking down to where now there's just a little bit of flow around the outside. And now we're there. Right here, there's no flow in the blood. Oh, there's a little flow there.
Now,
right there, yeah.
Now we're
That's good. So now here, you can see there's no flow. There's a little flow there, but we're actually outside of the blood vessel. So this is where we're in that dissection plane. So as we come back, we're going to see the vessel is actually over here. So you can see we're in the dissection plane here. So we're coming back, no flow.
It could be in it there.
I think that's still.
It could be in its plane.
I think that's just where we angioplasty.
That's the dissection.
Yeah. So we see we're outside of the blood vessel, which again is fine. This is just what we had to do to get through, get across it. And now as we're coming back to the top, We should be popping back into the vessel soon. Right there, right there. So now you can see this nice big blood vessel. So basically we're going to connect that to the end, to where we're in it. We're connecting the two dots. So until about 20 years ago, we would only be able to do that by putting a new blood vessel in there, a bypass surgery, where we would sew we still do that sometimes, what's called a femoral to popliteal bypass surgery. But that's a surgery. It's got risks, benefits. This patient particularly is very sick. You know, she's got problems with her lungs and heart, so she wouldn't be a candidate for open surgery. But now what we can do is connect those two dots, basically using a stent, which is a metal tube that'll connect the two dots. So right now what we're going to do is we're going to use a technique called atherectomy. So atherectomy is removal of atheroma, which is plaque. So what this does is a device that has a sharp blade on it that spins 2,000-3,000 times. How fast does it spin?
15,000 RPM.
15,000?
15.
Okay, so it spins pretty quick, and it cuts the plaque, and then it sucks the plaque out. So basically what we're going to do is kind of try and remove some of that plaque before we put the stent in. Basically open this blood vessel as much as we can. So that's going to be our next step, atherectomy. Okay, so this is the catheter, so you can see it has a blade on it, and so that blade's going to spin very fast, cut the plaque while we have negative suction on it, and it'll basically be cutting the plaque and sucking it out as we go. Ultrasound also allows us to get accurate measurements of the blood vessel, so we know exactly how big the blood vessel is, so we know as we move forward when we use balloons and stents exactly how big a size. We don't have to guess. If you guess wrong and put a stent that's too small in, it may move or may not work. If you put a stent that's too big in, you can injure the blood vessel or rupture it. So IVUS is really essential nowadays to us, being able to provide the right treatment for the patient. Okay, so here's the tip of the atherectomy. So we're gonna turn it on, and we're gonna cut probably from here to here, just that first initial area. So we're turning it on, and that blade is spinning. You're gonna see now we're aspirating blood and debris as this is cutting, because we don't want that stuff to flow downstream. And we're just gonna go nice and slow and really carve out that blockage. Come back. It's that one area where the blockage starts. Because once we can get through there, the rest of it's in that dissection plane. We're going to do the same thing down at the bottom where we go back into the blood vessel. Alright, Pete, we're going to use the longest 6 stent, 615. Okay. 615 stent and a long 6 balloon, 620 balloon. Do is before we go to stent, we'll just take a little picture. Remember, there was no flow in it before. Okay. So we have flow now. Okay, it's not great, but we have flow through it. So we're open. It's probably again in that dissection, but we're not done yet. But we've opened it up and we've gotten flow through that vessel.
Here it comes.
Okay. So again, we're going to go to there. Pete, just put a little, when you're done, put a little mark on the screen there. So now we've got it open. It's still not great, but what we're going to do now is we're going to put a stent in. So A stent is a metal tube that will go in and it'll open up and it'll actually hold that blood vessel open. So it pushes all the plaque against the wall and it creates a new blood vessel inside the old one. So this is a stent. So the stent is actually in here. Okay? So the stent is inside this catheter. We're going to put this catheter in, and then what you'll see is we'll pull back and you'll see the stent deploy. You'll see it flower out and open up. So this is the end of our stent. This is where we want to at least go to that black mark. So we're going to start below it. We could always pull it back a little bit. So Dr. Davis is deploying. You're going to see this start to open. Stent flowering. You see the stent opening. You can see it open. I'll take it.
6:15, you said.
Yeah. Okay. So that stent is deployed. Again, we're not done with it yet. What we're actually going to do when we're done is we'll blow up a balloon inside that stent and open that stent fully. But before we do that, we're going to put a second stent. So what we're going to do now is we're going to see where the blockage starts, and we're going to try and connect those two. All right, so here's the end of our first stent, and we're going to see how far we got to go with our second stent. Yeah, they will definitely make it.
Yeah, but you will.
Yeah. Okay.
Just into the ring.
We're going to come right to the top there. Yeah. We will keep coming. Two stents put in there. Now what we're going to do is put a balloon inside and blow the balloon up to really expand those stents to their maximal size. These are 6 millimeter stents, and this is a 6 millimeter balloon. So we're going to fully expand the stent. Once it's expanded, it won't compress. So I'm blowing up this balloon inside the stent. So you're going to see that stent really open up. Now remember, when we first started, there was nothing here, right? We took a picture and there was nothing here. Now look at that big fat blood vessel.
Just merging into the preserving.
You say perfect?
Near perfect. Like Michelangelo, it's never quite done.
So again, remember there was nothing here, right? It was all coming through those side branches. Like the day she was born.
think it's open, it's just...
Yeah. So right here, just a little, we're just going to hit that with the balloon again.
It's obviously open.
We should extend the stent to it.
Well, let's see how we do. There's a lot of venting in the artery. Yes, if they pop to obstruction. There's a big accident.
Yeah. Okay, we're going to balloon this angioplasty right here. See that?
Sometimes ballooning is all you need. Just a little extra ballooning. And we shall see. Pretty good.
Yeah, that's nice.
So they're just the vessels.
So again, there was nothing here. Remember all those collaterals? You notice they're all gone now. All that blood that was coming around here, it's all gone because it's coming down straight row. She'll basically, her pain will be gone immediately because the pain is from a lack of blood flow. You know, the blockage, in this case the occlusion, didn't allow any blood getting down there. So any activity where the muscle required more oxygen wasn't able to be delivered. But now, with that blockage gone, that occlusion gone, there'll be no pain. No pain with walking, no pain at rest. Some people have ulcers, the ulcers will heal. It's basically you're restoring the muscle, the organ, the end organ to life. And the effect is immediate because the blood flow is, you know, in this case went from 0% to 100%, right? Went from 100% blocked to 0% blocked. So you can't get a more, you know, contrasting, you know, than that. And so the improvement is going to be dramatic. And when we're done, we're going to close it with a plug. This device is called an angioseal. Basically, back in the old days, we'd have to hold pressure for 20, 30, 40 minutes, put sandbags on. Now we actually just close the hole in the blood vessel that we made. And it allows for them to be able to ambulate very quickly. They don't have to stay long and limits the risk of getting hematoma afterward and some of the complications that we used to experience. This has been really helpful for the patients.
If you have leg pain while walking that's relieved with rest, you may be suffering from peripheral arterial disease, also known as PAD. At Milford Vascular Institute, our highly skilled vascular specialists can diagnose and treat PAD using the most advanced, minimally invasive methods available anywhere. To schedule a consultation with one of our vascular specialists to discuss your symptoms, give us a call today at 203-418-7386, and it will be our pleasure to care for you.